Hey,
Morning, Lawrence. How are you?
pretty good. I was going to say, looking a lot better, Ryan.
I'm telling you, Ryan's been growing his hair out a little and, youthful makeup, getting in touch with his feminine side.
That's a good job you did there. Big
There you
improvement.
go. Yeah, nope. I'm your fearless host today. Well, your fearless tech host.
Yeah.
I think
How
I'm
you doing?
fearless. Pretty good. It is cold. It is, I don't need to tell you, but even the office hasn't warmed up much. So it's like the first
Yeah.
struggling.
One of my faucets didn't even come on. I don't know why.
Oh,
I lifted it up, but nothing.
it's frozen. Yep, I've heard from a couple people who, Jessica in our office had some trouble with one of her hot water. My parents out in Chamberlain said the hot water in their kitchen had frozen. And so, we're doing the South Dakota thing, space heaters and whatnot. I mean, you've even gone from black turtleneck to black hoodie. That is, that's an upgrade of warmth.
Exactly.
Awesome.
No, I didn't turn the heater on in my studio, so so I didn't have it on last night. So I turned it on this morning. Oh, Peter's in the house.
There he is. Hello, Pete.
Hi, everybody. How you doing?
Doing great. Just, doing the South Dakota thing and talking about the cold and which faucets are working and which heaters are on and which clothing we're choosing. And
Yeah.
so, another day in South Dakota in January.
Yeah.
Yep.
I'm clearing Christmas detritus from my life right now.
There you go. Yeah. Those, they look lovely. I hope they got used properly over
Yeah, they got used well.
There you go.
This stuff is like I'm buried in it now.
Oh, well, I'm looking forward to this. It should be very interesting.
Yeah, same here. It's been a while since we caught up. So Lawrence and I had a chance to chat a little bit the other day. And I'm always curious to see who will show up, because the people who show up always ask good questions. So
yeah, hopefully we'll have a nice little crowd here on Zoom, and I'll be watching the Facebook stream in case any questions come in that way. So
yeah, I haven't looked, but I think Nicole Plessick at the med school had scheduled some posts strategically
perfect.
to help promote this.
That would be great.
Yep, there it is. Yeah, so yesterday, first thing in the morning, I guess, she put that out there with a link to the SDHC page.
Excellent.
Yeah.
The more directions we can hit it from, the better. So
yeah, she's been great. I didn't know until about last week that Pete Carrolls, who puts together South Dakotan MD magazine, is retiring from the med school, and he had kind of been the lead in the marketing machinery, if you like, over there. Nicole actually works for the USD Foundation, which she handles the med school's social media.
Sure.
And she's otherwise a foundation liaison to the med school, but for alumni relations. But Pete's on his way out, and she and Eric, who's the graphic designer, and the other folks have been great in terms of just keeping the ship afloat and continuing to put stuff out there.
Good news. You need that.
Move this, actually. It's a distraction for me, if for no one else.
Bringing back memories.
Yeah, no, it's good. I mean, it's all good stuff, right? But like, it's
Well, gingerbread. How can you go wrong with a gingerbread?
Lovely.
still sitting there. Yeah, better. Candy falling all over the place. Okay, better.
So is that a hat behind you from Burkina?
No, those are baskets from Uganda.
From Uganda. Oh, okay.
Yep.
Oh, I see. Okay. That the one in the middle was the one that kind of got me. It looked like one of those Burkinabe hats, except that but it has a more of a point on the top. So I couldn't see it over there.
Yeah, it's for covering food, so it has a bottom part to it. We use it for, I mean, people there would use it for chapati, but we use it for tortillas a lot. We probably don't eat chapati as often as I want to at home.
Well, chapati is, until you get the rhythm, it's not one of the easier things to do right.
Yeah, and I'm picky about it because the best people to make chapati are the street vendors who make it on a cast iron flat griddle, and
Exactly.
so it's like, it's one of those things. It's like having all the right gear at home doesn't make a whole lot of sense.
Yeah, exactly. Well, you could always start out on, sitting out on the street and do that for about a couple of years. then you just want to just make chapatis.
I could do that. I would want nothing. That would be a full life for me. I love making chapatis. We had a friendly competition with my host family in Uganda about who could make the best chapati, and the joke was that I spent the most time in Busoga in the eastern region, where the best chapatis in the country are made. So I made the best chapatis. But
there you go.
but my host brother gave me a run for my money. He was very good at it.
For sure. Well, sounds like you got pretty dang good at it, though.
We had a lot of practice,
Yeah. Wonderful.
That is really the crux of it. That's where it all comes from. It's like, how many have you made, and where are you paying attention the first 10,000?
Yeah, right. Yeah, that's right.
And then the next 10,000, just a little bit of attention, and pretty soon you don't even have to think about it. Just like
just showing off.
Yeah, exactly. Well, the best chapatis I ever had was in Singapore.
Sure.
On the street.
Mm-hmm.
But you couldn't do, there was so much competition, you just couldn't do just a chapati. It was just like going down a pizza row. Everybody had well, you got your basic chapati, but then what do you do with a chapati? It's like they had all kinds of sauces and eggs and sausage and everybody had their own thing and their own way to fold it and all of that. It was like a major production, and you could just walk. It was like right on the pier, and you could just walk down the pier, and you couldn't eat it. You couldn't finish one. Yeah, like going down the whole thing in a day. So I just walked down the street, eating a half a chapati, and then walk to the next one, eat a half a chapati till I was too full. Then I come back and start where I left off the next day for about a week.
Yeah, where the Southeast Asians really take the competition to a whole new level, that at least in East Africa, with the street vendors that you see around campus and stuff that I was encountering, they don't even bother much with it. Is not just Singapore, but Indonesia. I mean, those folks are good at aesthetics, right? Food aesthetics. Cut a carrot to look like a flower. Like,
well, that's
it's
all
a
over
whole
Asia.
Other level of artistry with food.
Yeah, that's all over Asia, really.
Yeah,
it's like China, Japan, Indonesia.
We had this place in South Carolina.
Not so much Papua New Guinea, but
yeah. We had this place in South Carolina that was a Thai fusion. It was built into an old Burger King or something like that, like a lot of these places are. And actually, there's one in Sioux Falls that's in a strip mall like that. And my friend, who was the director of bands at Claflin for a while, the first time I took him in there and we were going to have lunch, he sat down, they set this plate in front of him. He said, "This is beautiful. I don't even want to eat it. It's beautiful." No, never mind. I'm hungry.
Yeah, that only goes so far.
Yeah, right.
Exactly.
Yeah.
That's right. Yeah. If I wanted to just look at the food, I'd buy a magazine, you know. But
Or
I can't
that's when you can take a picture, right? And
take a picture. Let's go.
Yeah, Jennifer, how was the feedback from the book festival? I was able to catch, some of the virtual events, and I know you're operating in a whole new world now for the second time on a virtual book festival.
yeah. It was generally pretty good, and our attendance did not, what I heard from other book festivals nationwide that had gone virtual or tried some version of a hybrid festival was that their attendance was way down, like 40 to 50% down for their events. And ours was actually pretty steady from the year before. So I feel like that's one good thing.
Go on, South Dakota.
Yeah. How about
That's
us?
good.
So even and in spite of all the virtual burnout that a lot of people are feeling, I think that's a good sign. And then people appreciated the programs, and we got good feedback on whether they were worthwhile, and the various authors and panels. So it's always good. It's we're getting much better at doing that. I do hope we don't have to do it again.
Yeah, I bet. I often wonder if South Dakotans appreciate the virtual element in a little different way than folks in other geographies, just because it's a massive benefit in terms of drive time.
Right.
We're obviously willing to spend the windshield time here, and people do it all the time, but even if we give something up for virtuality, we have maybe more to gain there than some other folks in other geographies too.
Yeah. And I found both years that, whichever side of the state the festival was held on, we got people who were from the other side of the state who would not have been able to attend in person, who expressed thanks for that. And some people in other states as well, that would never have seen it. So
sure.
Well, we just did a international conference not so long ago on how to wrap gifts with Feroshki, which is a cloth gift wrapping thing. And so that's an example of how when you go on a Zoom, you open whatever you're doing up to the whole world, not just to more South Dakotans.
Yeah, I got an RFP yesterday in my inbox that I would have deleted much more quickly in previous years. And now I'm thinking about, okay, like I can only think about going to International Council for Traditional Music like maybe once every 4 or 5 years. Now I can dig down into like the African Music Study Group, which I couldn't even dream about before, because they would hold it in like Accra, right?
Yeah, we're on our getting ready to showtime though. I see panic look in Jennifer's eyes.
Oh no, I'm setting up the Facebook. So,
Very
but
good.
now that it's 10:29, we have a few people in the waiting room, so I think I might start admitting them, and then start the Facebook stream, and
okay, then we'll be ready for it.
I'll give you the thumbs up. Yeah. So, all right, excellent. Here we go. Okay. Right. And now it's up to you, Lawrence, if you want to take a minute or if you want to go. We're headed out.
We're going to get started. We're ready to party here.
Very good.
Welcome, everybody. You're tuned in to one of the stellar events in South Dakota right now. And we have as our guest, Peter Hosing, and we're going to be talking today about interdisciplinary activities in health. Okay, we'll fill all of that in. That's kind of like a teaser. We'll fill all of that in a moment. But first, I want to welcome all of you and remind you that the basis of this particular effort is to get people to have a conversation. And there are a few reasons why we do that. One is people really get it better if they engage with a subject where you toss ideas around. And, you know, it's not so important that you have the right idea as much as you exchange ideas, whatever you think, because even if it's like not quite on the mark or not on the mark at all, the conversation that it will stir will bring up ideas that probably nobody had in the group anyway had thought of before. So it's always useful to have people to interact with us. And the other reason, or another reason, is that we really do need more practice in conversation. And we hope that this is a safe space to have a conversation where everybody respects everyone else and you know, gives everyone else a chance to contribute and respects other people's contribution, even when you disagree, or especially when you disagree. But it gives us a chance to like wrestle with that and to like check on our emotions. Like, well, how was I feeling? Why did I feel that way? Why did something turn in my gut when that person said this or that? It gives us a chance to like wrestle with that in ourselves. And then that'll make us more comfortable in having conversations with other people in other venues. I hope that's one of the intentions. So with that housekeeping out of the way, Peter, how are you today?
Very good. Thanks so much for having me on the program, Mr. Diggs and Jennifer Widman and everyone at the Humanities Council. I'm grateful for what you do to tell the stories that define our state and to encourage civil conversation. So thank you so much.
Yeah, thank you. Can you tell us a little bit, because some of the people, Peter's been with us before, but some of the people on the call may not be familiar with you, may not have, they may not know who you are. Can you give us a little bit of your elevator speech or your whole elevator speech?
Sure. Yeah. So my disciplinary background is in a field called ethnomusicology, which is a humanistic social science. And the main body of my research in that field was focused on Uganda, in two areas of southern Uganda where I worked with traditional healers and the musicians that they work with. So I've had a long engagement, ethnographic engagement with African music and with intersections between music and healing. Long prior to that, though, I'm a Midwestern kid, born and raised in South Dakota and Iowa. My family moved to Iowa when I was about my youngest son's age, about 7. And we lived in small towns. And, you know, I lived in Madison, South Dakota, where I work now at Dakota State University, till I was about his age. And then we moved to a town about that size in Iowa. And so I'm mentioning this about rural communities because it does come back to touch my work in Uganda later. It took me a very long time to realize that some of the fascinations that I had about people's concerns with the relationship between their communities and their bodies and the land and the domesticated animals that they keep were familiar concerns to me. You know, I'd probably been back and forth to Uganda 2 or 3 times before I realized, this is not new to me, right? These are the same concerns that folks in South Dakota and Iowa and elsewhere in the Midwest and rural communities have about the animals that they keep and the crops that they keep and the communities and families that they keep.
That's one of the very interesting things that happen when you travel around, is you start to notice how much people are much more alike than they are different. You know, some of the same kind of concerns they have and frustrations they have. They may say it in a different language and they may have a different beverage at coffee, but pretty much everything is the same.
Yeah.
Yeah, good.
Yeah.
But you're doing a program now on shaping medical humanities in South Dakota. Can you tell us a little bit about that program and what you're trying to accomplish? Because that's the kind of thing we're going to be talking about today.
Sure. So recently, Ryan Woodward got in touch with me, and I had submitted a final report for a summer grant that we were grateful to have received from the Humanities Council to do some work in partnership with the USD Sanford School of Medicine and all of our sites statewide, called Shaping Medical Humanities. And Ryan picked some pieces out of that final report, and so some of you may have seen that on the South Dakota Humanities Council website. The basic premise of that project is that we know there are artists and humanists doing interesting work statewide, and it's not hard to imagine that lots of that work might intersect in some way or another with human well-being, writ in the largest, the broadest possible terms. But we also did not want to pretend that the only folks sort of doing that in partnership with the med school could be in Vermilion or Sioux Falls or or even at one of the other sites statewide in Rapid or somewhere else. And so we set out to map other assets, meaning human resources and programming and all kinds of things that people are doing statewide that might be right at that intersection between humanities fields, arts fields, and health and healing. So that's a pretty big container, right? That's a big question, and it was purposely broad. And so when we wrote that proposal to Humanities Council, my collaborator is the director of a center at Sanford Health called the DeGroat Center for Bioethics, Humanities, and the Healing Arts. Her name is Ellie Schellinger, and Ellie's been doing health humanities related work and bioethics related work at the DeGroat Center for quite a long time. And she's been a member of the Ethics and Humanities section of the med school faculty for, at least a couple of decades now. So when we started to map out these assets, we were really looking for, as this crowd knows, humanities could be diverse by discipline, right? That could mean somebody who's an elder in their community and a storyteller, as easily as it could mean a citizen scholarship, community historian, somebody who's contributing to a local historical society, or it could be, an author or a poet, or it could be any number of things, or it could be somebody who's working in an academic philosophy department. We wanted to capture the most complete picture we could muster in the time we had of any of those folks whose work touches health and well-being in any way, so that we could begin to ask some better, more focused questions about how we might work together and collaborate on a variety of things. So there are a number of people who have been involved in that work in South Dakota for a long time. One of those folks is Dr. Matt Simmons, who's the campus dean of the Rapid City campus for the School of Medicine. And he's put together a number of arts and humanities collaborations with local nonprofits, West River, that have benefited his students for years now. And his, we talked at length during this project, and he likes to say, well, I like to get something started with a museum or with a gallery or with a partner of any kind. And then hopefully, if that's mutually enriching for the students and for the site, then it kind of runs itself as, something that's integrated into the curriculum. And that frees us up to work on the next collaboration. I really like Dr. Simmons' model for that. And the med school really likes that model is so focused on community engagement. So we have, some of those things that we're doing sort of at key points in the state geography, but we wanted a more comprehensive picture of not only what's out there already, but what might be possible if people could imagine their engagement in it in a little bit different way. So one example of kind of how that worked out during the project period is, we were doing virtual events and, visiting grand rounds, and we did a session with the frontier and rural medicine students, which is a subset of the medical students at the Sanford School. And then people would hear about this project, right? So one person got in touch with me, and she's a poet, and she had a journey with her cancer treatment. It was actually her physician who got in touch with me and said, would it be okay if I gave your information to this patient and she can get in touch with you directly, right? Physicians being careful about privacy and HIPAA and all of those good things. And I said, yeah, sure. That's absolutely what we want. So the person got in touch with me. She sent me a copy of her poetry chapbook. And now we're sort of engaged in a conversation about how we might integrate some of that work into the poetry that we use in the Medicine and Humanities survey course that we teach for medical students. That's one example of how people can imagine their engagement and participation in a project like this. But that could look a lot of different ways depending on what people's discipline is, right? If you're a community historian and you uncover something really interesting about a clinical site that's been shut down for 50 years, for example, that's a local history of medicine that's really fascinating. And history being a humanistic social science, we absolutely want to have a conversation about that. So I had a similar conversation about something like that with another person who's long been involved in the Keepers of the Hiawatha Asylum story, right? That's an example of a distinctively South Dakotan history of medicine story. Now we know from the Keepers of the Asylum, and some of those folks are South Dakota Humanities scholars, so they've been telling this story in South Dakota for some time. We know from the Keepers that it is as much an incarceration story as it is any kind of healthcare story, right? All the documents refer to people as inmates, not as patients. So we get that, but the medical establishment still has to come to terms with that painful piece of our regional history, right? We still have to use that to think about other ways that the medical establishment in this place of the world may have done really good work or may have run off track or anywhere in between, right? So we heard other fascinating stories from communities where, they didn't set out to do a medical humanities thing necessarily, but in the end, they put together some kind of arts collaboration or some collaboration around local history or some interfaith conversation, right? That turned out to be sort of medical humanities adjacent. And we started to hear these stories throughout the project period. So the project period ran from July to early October. So one of the challenges that we have now is that's a short project period for any project. We knew in the beginning we could not be comprehensive about this, but we wanted to be as inclusive as we possibly could be. So even in the proposal language, we said, we're going to do a draft asset map that will continue to enrich over the next couple of years. And we're going to do a preliminary needs assessment where anybody who agrees to be included in that asset map also tells us something about what they might need to be more engaged or to develop whatever that next collaboration is going to be. So those are kind of the two prongs of this project. And it was fascinating, and it continues to be fascinating. And we have gotten tremendous support from the med school leadership to continue enriching both of those resources over the next couple of years. So, and at the end of the day, I'm going to fast forward. We really envision an interactive web-based resource that people in South Dakota and in the region could use to begin a conversation about these kinds of engagement. The examples I gave you just now are just a few, but to imagine what their engagement might look like, to find other people in the state who might be logical partners for that kind of engagement in health humanities or in medical humanities, and then to have some pathways to move that forward.
So it sounds like there is a lot of room, or you might even say motivation, for interdisciplinary studies where people sort of cross-fertilize in disciplines. Can you talk about how those disciplines would come together to impact public health, or the efforts in terms of the medical intervention? What does that look like?
That's a great question. So I'll use as an example a story I heard on the radio yesterday, and it's not from South Dakota, but it's a great example of what something like this could look like. It was a story about a former photojournalist who, and I'm picking this story because I see Kevin Worcester's here, and so it makes sense to tell a story about a journalist. He got tired of being an observer who felt powerless to change any of the situations that he was observing. So he trained to become a nurse, and he's a registered nurse now, but he still has that photojournalism background, and has found ways during the pandemic to photograph patients and families and work around all of the complicated structures of permission to do something like that in a clinical setting, which, by the way, is a formidable task, right? In order to tell a story about a public health challenge that we've never really seen anything like before, from a health provider's perspective and from a patient's and family's perspective. And he's curating those perspectives together in a fundamentally interdisciplinary way, both as a let's say an artist, right? A photojournalist that's a little different from photography as an art, but he's taking this art form and putting it together with a fundamentally applied science pursuit like nursing in order to tell a fundamentally interdisciplinary story from perspectives that he regards as really more his patients and their families than his own.
But it's interesting that you mentioned the photography, because you can see how, or I can see how you could use that to tell a story not only to the world, but perhaps more importantly, to the patient about what's happening to them, or to the community about what happens in a medical setting, to give people some kind of better knowledge and more of a connection with medical interventions. Have you found anything like that where there's feedback, or is it too early to tell?
No, I don't think it's too early to tell at all. I think once you start to see the variety of examples, you realize that they're really all around us. So we used to call this kind of thing narrative medicine or participatory narrative medicine. And in many ways it still is, right? There is a narrative that nurse is shaping, and it has a particular perspective, and it has a strong positionality to it in terms of trying to encourage people to get vaccinated. And the nurse could tell you more about his own position on that. But what used to be an enterprise where, maybe a provider might ask a patient to get involved in telling their own story as one part of a multimodal therapeutic intervention looks much different in the current technological environment. So I'll use a different example. There's a OBGYN in New York City named Dr. Heather Irabunda, and she's doing narrative medicine in a really different way than I've ever seen before. She's doing it primarily on TikTok and Instagram, where she's putting out, reliable medical information in an environment that she knows is rife with either lack of information or misinformation and disinformation from an authoritative physician's perspective, right? She's an Ivy League educated physician. But in a really informal voice, right? And encouraging a level of engagement from a patient community that reaches well beyond her own practice, right? She can reach a whole lot more people on social media than she ever is going to be able to see in the exam room. But she's still getting a level of engagement from that patient population that's international at this point in order to tell a story about women's health from a really particular perspective, that normalizes conversations about things that have been made taboo that really oughtn't to be taboo, or that check out Dr. Heather Rabunda. You'll see what I mean. But it's a great example of how narrative medicine has changed because the technology has changed, right? We're not just dealing with writing as a technology. We're dealing with multi-platform storytelling as a form of writing.
What's interesting is the potential for feedback and
Yes.
ripple effect through the community. When, I remember back in the days when computers, personal computers were pretty new, and somebody brought out a Mac Plus. And even before that, just, the pre-Mac Plus iterations of various, 2G and all of that. And most people had never seen any kind of computer, let alone one that you could put on their desk. And the challenge of the manufacturers is, well, who's going to teach these people how to use this thing? And they didn't. And the manuals that they wrote were just, what? It's like, maybe you can make one of these things, we have no idea how to use it or what it's used for. And the result was people just sort of taught themselves, and through that ripple effect. But they had people from Apple that would come out and sort of give you a sort of a baseline and answer technical questions. But mostly it was like people, each one teach one. So I'm wondering if that kind of potential is expected or realized, or have you seen any examples of that so far?
Yeah, that's a tough question for this project, and I said this before, but I want to repeat it and emphasize that that's part of why we want to be inclusive without attempting to be exhaustive, because the minute we attempt to be exhaustive, we're going to miss something, and that's upsetting for people. Inclusion is the name of the game because we want to hear about as many fascinating examples of how people are engaged across disciplines and how they're engaged in interesting practices of feedback and patient response and all of those sorts of things as we can, but not as a way to sort of control what's going on, more as a way to celebrate what's working, and to think about that in South Dakota's geography that's a particular set of challenges. We were talking a little bit before the session started about what that means for the book festival that Jennifer organizes, but it means some similar things for any kind of virtualized environment, whether it's social media or classes that are held online across 3 campuses in a med school, or a practice of patient feedback that hopefully could be more inclusive in a virtual environment than it ever could in an environment where that would require patients to travel to a single point in the geography. So that's getting pretty far down the proverbial rabbit hole, I feel like. But I'm fascinated by Dr. Rabunda's work. I'm fascinated by the work of patient poets who are navigating their way through a protracted disease narrative that they would very much like not to be the authors of, but they find themselves the authors of that narrative. And I think those stories are also the stories that define our state, right? We are all at some point along the way patients, even if we are not at some point along the way healers. And that means that we all have patient stories, and some of them are just absolutely jaw-dropping in what they ask human beings to do and accomplish and overcome, and who these stories put people in contact with and what those folks do together. So whatever discipline tells those stories in the most compelling way, I'm sort of discipline agnostic at this point. I don't care. It's part of being, trained in a field like ethnomusicology, which is fundamentally interdisciplinary, right? We'll find the research methods or the collaborative methods that we need in order to tell the story. But let's get at the story, because there are some absolutely fascinating and inspiring stories about South Dakotans out there, and their struggles and triumphs with health and well-being.
I have a whole bunch more questions, but I want to open it up to our audience.
Yes, please. I want to hear from the audience.
At this point. Any questions that have entered your mind that you can share with us, or comments?
I really want to hear from folks about how they see themselves in this project or in this kind of work. And just as important as that, if they don't see themselves, what might they identify as barriers to that? I would just leave it there. Yeah.
Don't all speak up at once.
First, I'd be interested in knowing, is there anybody with Sanford that's doing the kind of work on social media, or within the community in South Dakota doing the kind of work on social media that the doctor you mentioned from New York is doing?
There are a few. I would say the scale of that is a little bit different. But I've been sort of thinking as part of this project about how to address that. Like, do we need a Follow Friday on the School of Med's social media presence? Or, I haven't quite landed on the tool for capturing that information and then curating it or sharing it. But yeah, there are some physicians who are vocal about public health issues, or they're vocal about COVID issues, or they're vocal about the nitty-gritty things that they're doing in their practice and how they're related to public health issues. But I wouldn't, at this point, I wouldn't pretend to be an expert on who all is out there doing that, because I'm just starting to hear about folks now, 6 months after starting this project. So
I've personally had a variety of health issues this year, which have limited what I can do. And I've written about it to a certain extent. I think some of my family, Jennifer is on, I see, may think that I've written about it too much. And I'm discouraged sometimes by my family members, especially my wife, from writing about it anymore. Oh God, she says, another story about the lesion in your brain. That's just what we need to hear. And there is a drive, if you have that, and you also have a communications history or a art history. I also try to write poetry. And I've had doctors and a lot of doctors, medical doctors, psychiatrists, psychologists. A couple of them say to me, do you think you're sharing too much? And I could tell that one of the doctors was, because you're getting a little close to sharing stuff about what I'm doing for you. And there's I try to respect the doctors that I've involved in. And I would tell you that if there is a criticism that I have of this marvelous healthcare system, it is that there isn't much art there isn't much, I wouldn't say there isn't much, but there may sometimes be a shortage of humanity in what goes through our process together. And I wonder how comfortable doctors are with the process of having an artist open up this, or a journalist open up this process a little bit more.
Yep, I have that same question knocking about my mind every day, Kevin. Especially because I pretty consistently find myself in a room that is mostly peopled with physicians. So I'm the outsider, right? From a disciplinary perspective. I don't know how quite to respond to the dynamic that you're referring to. I've heard you talk elsewhere about this dynamic with your family and your physicians. I think I heard an interview on Lori Walsh's show with you. Is that right? And except from my own admittedly biased perspective, I think it's wonderful when patients tell their stories, regardless of what's happening in the patient's life or their health journey, because I believe that it's a means of claiming some ownership, which is not the same as claiming control. Sometimes that's possible and sometimes that's not. But claiming ownership can have a significant impact on people's disposition relative to their situation. And try to tell any patient involved in a protracted disease narrative that doesn't matter. Good luck. I'll wait. It absolutely matters. There's a well-documented history of how much it matters to patients. And a lot of that history is documented in narrative medicine, right? And in medical ethnography. So it's documented elsewhere too. It's documented in medical journalism, as you pointed out. But I feel always that it's a privilege for the rest of us to have that level of access to what's really highly personal for people. So I want to thank you for sharing your story. And yes, it produces uncomfortable situations. That is as true of any of the other examples that I mentioned as I'm sure it is for in your case, Kevin. But I also think there is some value to that discomfort and to working through that discomfort.
I think it's worthwhile remembering that when we take our first breath, that's a little uncomfortable too, and we cry about it. But then after that, we get used to it. Now we don't like people to stop us from breathing. So
that's a wonderful analogy, Lawrence.
Things change.
Yeah. Let's hear from some other voices if we can.
Yeah.
Good morning.
Good morning.
Good morning.
Good morning. My name is Crystal Owen. I'm a member of the Sistine Wapton Oyate. And I do a lot of work with, I love this idea. And, you know, I believe that storytelling is life-saving and it's life-changing. You know, I've been telling stories for a while now, sharing, like I'm also a hospice volunteer. Right now I'm a community outreach advocate for a domestic violence shelter. And so I've had 8 relatives that were killed by a drunk driver, you know, about 18 years ago. And since then I've been telling the story, and I've been sharing on grief, on death and dying. I've shared stories on death and dying. I've made my own little video storytelling on all of these issues, because I believe, like, even diabetes, there's 9 people in my family and 8 of us, our brothers and sisters, are diabetic. I was told a story, you know, on D-Life TV about that. So I love the idea of storytelling and the power of healing in stories. And so I'm really excited to hear more about this, because I really think that even, you know, with COVID right now, telling our stories about mask wearing, the importance of mask wearing, I don't think that we can ever share too much. And I think when people see each other, when they, you know, all these TikTok videos, look at how they're going viral. you know, a lot of them. And I think that the doctor in New York that you mentioned, I think that's great what she's doing. And I'm excited to see more of it happen in South Dakota. I'm not a professional like video photographer or anything, but I take thousands of pictures, and that's what I use when I do presentations to tell a story, or in any facilitation that I do, because I think they're powerful. So I hope that, you know, that as part of our tribe, the work that I do, I hope that somehow I can be, I don't know if there's going to be I might have missed it in the beginning, an application process, or, you know, that we can get some support in our community to help our people, because our cancer rates are high, our diabetes rates are high. And how do we help our people to take better care of themselves? You know, I think by telling a story. I'm always like, you got to tell your story. You got to tell your story. Let me interview you, you know, even if it's on, you know, we go Facebook Live, but I believe there's a lot of power to that. So I'm excited about your project. Thank you.
Yeah, and thank you
Crystal.
for sharing all that. I really want to say thank you for the work that you're doing with hospice, and you know, presumably there's an elder component to that.
Yeah.
But not always in a hospice situation, and both ways that can be really heartrending, and it's tough, exhausting work. So thank you for the work you're doing for your community. Crystal, I would love to stay in touch and explore some of those questions further. We've heard from a variety of storytellers statewide, some of whom are doing work that's somewhat similar to what you described, and others of whom are, you know, their work's a little bit different. But, you know, you're exactly the kind of community enthusiast that we're looking for as we continue this work. So I don't know what that means for collaborative possibility, or for you know, the future of the work that you're doing, but beyond the kind of assessment phase, which was kind of phase one of this project, we definitely envision some applied engagement, and the main reason we haven't been more definitive about how we want to shape that yet is because we don't really feel that it's completely ours to shape, right? That project belongs more to patient and provider communities statewide than it belongs to a medical school. If we can provide, you know, some support in terms of collaborating, curating, and sharing those kinds of things, that's probably closer to our role. But really, the stories belong to the people of South Dakota. So yeah, so let's follow up. I'd love to continue that conversation.
Yeah, that sounds good. Thank you.
Yeah.
Anyone else, some comments or questions, things that you've seen, heard?
Lawrence, I can share a comment that's come in on Facebook that I think relates pretty nicely to what Crystal has just talked about. So I'll read it to you because it's a little bit lengthy here, but it comes from Jessie Daw. She says, I'm a patient advocate in the myeloma space. E.g., I founded the Eastern South Dakota Myeloma Support, serve on the Oncology Patient Council, attended the American Society of Hematology conference last month with the International Myeloma Foundation. And in relation to what Pete had said about perceived challenges or sticking points, she's struggling to see the connections in the project. She's very interested in humanities, and she feels patient stories are so important, and our local group serves a need here and helps us connect. And one thing she points out is that many myeloma patients have never heard of this disease before being diagnosed, which I think is probably not an uncommon situation with a lot of diseases. And it can be quite a lonely experience when others don't understand it. So she's trying to think about how her group could contribute to this project, how the members can benefit. And she's wondering what the focus, Pete, for you is the progress. Is it for the program focused on patients, physicians, both, others? How would you kind of explain that? What is the focus for all? Is the focus for patients? What would you say?
Yep, great question, and thanks so much, Jesse, for your input and for your engagement here. Patient advocacy groups are one of the things that we saw pop up across this project and beyond. And the answer to your question about how members of a group like that can benefit depends on so many variables in terms of what kinds of information people are willing to share and what their physicians and the health systems that are helping to care for them are comfortable with them sharing. And so there's some of those issues to work through in a situation like yours. But I guess my best answer is I don't know yet. And I would, it's a kind of a similar answer that I offered up to Crystal's input. I don't know that it's entirely up to me or even to the med school, right? I think that's up to the collaboration that we put together. So I would welcome conversations with patient advocacy groups, particularly in situations like yours where people don't maybe understand the affliction very well. So some of that's about awareness. But some, no doubt, is also about the stories that any individual patient tells, and the kind of claiming ownership of your path kind of thing that we talked about with Kevin. So I mean, I think that's what I hear you saying when you say patient stories are so important. I certainly agree with that. I don't yet know what the texture of that is in the future of this project. But your question is precisely the kind of question that I'm trying to get to through this project, right? I want to hear from individuals and groups statewide who are doing this kind of work, and I want us to think together about how we move that forward in a way that so my priorities in the med school are moving it forward in a way that educates the next generation of physicians, right? But very early on, when I went to the Dean of Medical Education with this idea for this grant, I said, I don't think med students are our only stakeholders. I think physicians statewide are also stakeholders, and communities of care, so other healthcare providers, are also stakeholders. And most importantly, I think individual patients and what the medical anthropologist John Jansen calls therapy management groups, which the myeloma group would be maybe one of those, but families can also be patient therapy management groups. Those are also stakeholders for this project. And when I said that to the Dean of Med Ed, it took less than the time for me to get the rest of the sentence out of my mouth before he agreed with that, right? So there's a big part of this that they know is about meaning the school leadership knows is about community engagement and about sort of how patients and families and communities claim that ownership of their medical narratives that the med school is deeply invested in. And I've been really encouraged by that response, not only from Dean Beard, but also from Dean Ridgway, who's the Dean of the Med School. So I know that's not a clean answer. I know that's not a simple answer, but that's because I don't think the answer belongs to me. I think it belongs to us collectively. So again, I'll leave you with the same endpoint where I left others who've chimed in previously. I hope we'll continue that conversation, and I would love to be in contact with you and your group and hear from other members of that group about, what a linkage with the medical humanities program at Sanford School of Medicine how it might benefit the group, what it might mean to members of the group, what it might indeed mean to medical students, right? Is it important to tell the next generation of physicians these same stories?
Peter,
Betty,
just
go
that
ahead.
note, this is just a logistical question and then I'll bow back out. But would you be comfortable, Peter, with me sharing one of your emails in both the chat here and on Facebook? So that either Crystal or Jesse might be able to get a hold of you? And if so,
Sure.
Would you want it to be your DSU one or the other one that we have?
Yeah, you can share my DSU address. That's fine.
I will do that. Thanks.
Yeah, thanks for asking.
Betty, you look like you were chomping at the bit. You had a hot question.
Well, I just will share an experience that's history now, but I hadn't thought of it in this context. My late great husband was dying for 2 months down in Sioux Valley Hospital at the time, which was the med school hospital, I guess you could call it. And I stayed there with him for October, November until he died the 1st of December. And I guess I kind of took ownership of his situation because he wasn't able to. He came in and was intubated and on dialysis, and people didn't know who he was. But the first 24-hour period I was there, I went down to a music store and bought Miles Davis's Sketches of Spain on a small, I forget what you called those things you could wear when you went walking and listened to your music, because he was a professional trumpet player who had traveled the world and had known Miles Davis and Count Basie and played with several people that we all know by name on stages around the world. And his music was who he was. And so he was able to listen to that music whilst he was in the ICU. And come to find out, many of his physicians were also musicians. And I feel that I watched this happen. They spread the word, we've got this guy over here and he's been, and then they were bringing recordings to him. So he had this wide spectrum of wonderful music. They got to know him. They embraced him as a human being, and me too. I mean, I felt like they cared for me equally. It made what was a dreadful, difficult situation much better. And so I see now probably things like that are happening. I wasn't even sure they would let me bring the music into his room, but as it turned out, we really came together with that. And so that's a story that if I ever find my notes, I might write it down.
What a beautiful story. Thank you for sharing that, Betty.
Thank you so much.
At some point along the way, we went from a situation where people were sort of ignoring these default coordinators who were coming from families to employing professional clinical coordinators, right, at kind of at the other end of the spectrum. And now we're at a point somewhere in between where sometimes a clinical coordinator like that is available and they're on staff and they're tasked with doing this for particular parts of the health system. And in other situations, there's not the resources for that, or it doesn't, that person's position doesn't serve this particular unit or that, and so we still sort of have this residual situation where the default clinical coordinator is often a member of the therapy management group that's a family member or that's a close friend. That situation hasn't gotten any easier because the HIPAA laws haven't changed. And so that has to mean something in terms of what somebody like Betty's perspective means when a patient is going from clinical point A to clinical point B, or clinical provider A to clinical provider B, or like those kinds of stories are still really valuable for educating the next generation of physicians, so that when they're in a clinic, they find themselves in a complex clinical situation, they know to pay attention to the therapy management group, whoever it is, right? And they know that it could look different in every situation. They know that sometimes it's a cousin, and sometimes it's a mother, and sometimes it's a different parent, and sometimes it's a partner, and sometimes it's just somebody like Crystal who spends a lot of volunteer time in a space. And they know to pay attention to those folks and to listen to them. So that's one really clear line between these kinds of stories and what makes them so important.
I think Betty's story also points out how important it is for people around the patient to kind of get what's going on with the patient. And a lot of times they don't know about, let's say, whatever that dis-ease process is. And if they don't have any clue about what that person is, what that person's going through, rather, that could put other stresses on the patient, which may have limitations or things that's going haywire for them too, things that you would think anybody could do that, but they can't. And having stories that they can relate to, I think is useful. And I will say, I know myself, I've had a real turnabout about narratives. I used to think they were kind of like useless things that, that just give people the data and let them make their own stories. And then it's way too late came to me that many people can't do that. They can't make a narrative, or they don't think they can, so they can't. And so the narrative helps to clarify and connect, or as one inmate recently told me, it makes it relatable.
Yeah.
So I think that's important. Those kind of stories make it relatable.
Yeah, or even quite the opposite, right? Even if I'm capable of creating my own narrative, it doesn't mean everyone can relate to it. And yet there's still some value in perspectival diversity, right? If somebody's got a different perspective and it's really different from mine, that can hold up a mirror to me that's valuable on a whole other level. I want to take a minute to address a comment that Jennifer's put in the chat here from Brooke Neubaum. I hope I'm getting your name right, Brooke, who's a master's student at Indiana University in Bloomington in art therapy. She says, quote, "I'd love to see more art therapy representation in South Dakota. There's not currently any grad programs for it here," close quote. Totally agree. Same is true for other arts-based therapeutic interventions. So we don't have a training program for board-certified music therapists in the state of South Dakota. We do not have a training program for registered art therapists or board-certified registered art therapists. We don't have any other similar training programs for other arts disciplines here in South Dakota. This is only my perception of this dynamic, but I would argue that that's likely because we are encountering similar challenges to everywhere else in the country relative to arts-based therapies, which is reimbursability. If there's not a code for it that an insurance company will reimburse, that means it is automatically economically segregated from every other kind of therapy. And that's a massive challenge. It's a challenge that plagues arts and humanities folks who are working with and in healthcare systems. And there's no way that Sanford School of Medicine is going to solve that one alone. So I am glad to know that there are people connected to South Dakota who are at places like IU Bloomington, which is a tremendous university, who are thinking about this stuff. Certainly our med students are also thinking about it. They run up against challenges of reimbursability, not just with arts-based therapies, with other stuff too. And they're interested in the policy perspectives on it. And they are vocal about what they think about it in ways that are really inspiring and encouraging. So it's a big one. That's a massive question, the reimbursability thing.
But you know, that actually, I've been to some conferences, I think Betty was there too, where people there seemed to be some effort to bring that into South Dakota.
Well, look, if we can get nutrition prescriptions reimbursed in South Dakota, if we can get movement prescriptions reimbursed in South Dakota, and those are two things that are happening right now already here in the state. It's a glimmer of hope for other forms of reimbursability, right? It's a complex question that cuts across medical billing and coding and policy and disciplinary diversity in the practice of medicine and all kinds of other spaces. So it's not going to be a simple one, but I'm encouraged by those programs in places like Custer that have figured out reimbursability of things like movement and nutrition. That's huge.
Well, we're coming up on the end of our hour here pretty quickly.
Yeah.
And so I wanted to give you a chance for a few minutes to any parting thoughts, connections, things that we might do to let's say put some wind in the sail.
Yeah. Well, on Tuesday, I did a quick teaser piece on Lori Walsh's show In the Moment on SDPB Broadcasting, and she asked a question about how people could imagine themselves, in conversation with this project. This group has really offered up some fascinating answers to that question. I would encourage folks who are here and folks who hear this recording later to continue thinking with us about various answers to that question, because there are no doubt innumerable answers to it. And I'm fascinated to hear them. I certainly don't want to be in a position and don't ever want to pretend that I'm in a position to decide what all those answers are. So I'll just end by emphasizing that those are some of the stories that define our state, and that I'm privileged to be part of the conversation with South Dakota Humanities Council to find them and to encourage people to tell them.
Okay. Well, we've come pretty much to the end of our hour here. I hope that all of you have taken notes and can remember some of the things. And as Peter was saying, all of this, none of this really has any meaning until rubber meets the road. And that rubber meeting the road means when we each take some part in moving the puck along, so to speak. That means talking to our friends about it. It means, like Betty was saying, maybe writing your own narrative.
Yes,
maybe
please.
Maybe it's a matter of making some notes about what you experience when you have an illness, and maybe later it could be turned into a narrative, or maybe it is a narrative as you're writing it. But so there's so many ways that you can do that, and then so many ways after you do it that you could actually share it with others. But I think what we've done today, at least I hope we've done, is at least introduced you to the idea that that is a valuable contribution to the kind of global or community health platform. Peter, I want to thank you again for joining us, and I hope you'll come back again and tell us more about what the progress that you've made.
Yeah, well, thank you so much for having me, Lawrence, Jennifer. Thanks for all you do at the Humanities Council, and thanks to all who came and participated and are thinking about really interesting issues in humanities and healthcare in your communities. Thanks for your input. Thanks for coming today.
All right.
Thank you. Thank you very much.
See all of you next week, same time, same station.
Okay.
Thank you all. Stay warm.
Bye-bye.